Hello, my name is Darshan Mehta, and I am Medical Director of the Benson-Henry Institute for Mind Body Medicine at Massachusetts General Hospital, and I also direct our Office for Wellbeing in the Center for Faculty Development at MGH. I also serve as the Director of Education for the Osher Center for Integrative Medicine at Brigham and Women's Hospital and Harvard Medical School, and I'm an Assistant Professor of Medicine and Psychiatry. So my topic is entitled Integrative Medicine and Beyond for the Aging Women. I have no disclosures to report that are pertinent to this presentation. So what I would like to do in this presentation is a few things. One is to define integrative medicine. I'll discuss some of the epidemiology in menopause and women's health, explore commonly used practices amongst different domains. We'll look at some examples of recent research and just understand some of the new frontiers in clinical applications and research. So let's begin with a case study. This was a case I'd encountered during my training and which really interested me in the field. So I had a 50-year-old female with past medical history significant for depression who presents for a routine physical examination. She comes in with complaints of mild knee pain associated with weight gain. She also would like to talk about perimenopause as she's been experiencing hot flashes. Her family history is non-contributory. Her social history is she is married, she denies any tobacco, alcohol, or illicit drug use, and she tends to eat a lot of fast food. Her physical exam includes that her BMI is 31, her blood pressure is 130/80, and otherwise there are no other remarkable findings. Lab testing includes normal white blood cell count, hemoglobin, and platelet count. A basic metabolic panel was also normal. Her fasting lipid profile was normal. She had a normal hemoglobin A1C, and she did have a knee radiograph that confirmed some degenerative changes. EKG is unremarkable. The assessment plan looks like she has perhaps borderline or pre-hypertension, class 1 obesity, and she has perimenopause. So the plan was to do diet and exercise counseling. Now, diet counseling at that time was to eat less, basically eat less, and exercise counseling was to say do more. But she was not satisfied with that, and she wanted to ask me about the following. And she's like, Doc, what do you think about this? There are two supplements on the side, Remifemin, which is something for menopause, SAMe or S-adenosylmethionine. And then she brought this article with her. It's a special issue of Time magazine, is How Your Mind Can Heal Your Body. And the subtext were new ways to beat the blues. The link between mental and physical health is happiness in your genes, women, men, and depression. And so that got me thinking, what else can I offer this patient? The patient was very adamant in this case about not using any pharmacologic management. Hormone replacement therapy was not of interest to her in any way. But she had sought out she wanted to still be supported. And it really, this type of case and cases similar to this really pushed me into thinking about what does it mean, this whole field of what was known as alternative or complementary or integrated medicine. So I'd like to just share some vocabulary so that we're all together on the same page. If a non-mainstream practice is used together with conventional medicine, it is considered complementary. If a non-mainstream practice is used in place of conventional medicine, we consider that to be alternative. So integrative medicine and health really emphasizes a holistic, patient-focused approach to health care and wellness, often including mental, emotional, functional, spiritual, social, and community aspects, and treating the whole person. It aims for well-coordinated care between different providers and institutions. And this is the definition that is used by the National Center for Complementary and Integrative Health at the National Institutes of Health. And so what exactly is integrative medicine? Well, integrative medicine combines the best of conventional and evidence-based complementary and alternative medicine therapies. It emphasizes the primacy of the patient-provider relationship and the importance of shared decision-making. It seeks to optimize an individual's innate healing capacity. It emphasizes patient participation, for example, exercise, diet, stress management in maximizing health, and also emphasizes the contribution of the therapeutic encounter itself. So we do know that roughly 1/3 of United States adults used complementary health approaches in the past year for their health and well-being, and this number has been stable over the past decade. We also know that about 25 to 50% of peri and postmenopausal women use some form of complementary and alternative medicine or integrative health, and more than 60% perceive it to be effective for menopausal symptoms. So especially in this patient population, there's a much higher degree of prevalence than there is in the sort of general adult population. We also know that certain types of therapies have increased or exponentially increased in their utilization. So, and this won't come surprising, I think, to many of you. For example, yoga has experienced a huge increase from 2012 to 2016, and there's at least 50% increase. And meditation has had a 300% increase from 2012 to 2017. And over the COVID pandemic in the past year, these numbers arguably are probably going to be higher, only because we were forced to socially distance or isolate ourselves from one another. And so people looked for ways of connection, of community, to help support their own sense of health and well-being. We actually spend quite a bit of money and out-of-pocket spending on complementary and integrative health approaches. And these numbers are older numbers, but they continue to increase. And there hasn't been any recent statistics, but just to give you a sense, in using 2012 numbers, at that time there was a spending of just under $30 billion on complementary health approaches. And relative to the size of the overall spending expenditures, this number continues to increase more and more and more. And again, I think one of the things that we will begin to appreciate is that many people are beginning to look at other choices and make other choices, and often look to their healthcare provider to guide them in using these discretionary dollars. Now, with that being said, the number of visits have also increased for visits to providers that provide complementary healthcare practitioners. And in part, this is due to now there's going to be increased insurance coverage. For example, acupuncture is a covered service through Medicare for treatment of low back pain. This is also true for chiropractic care services as well. So these are examples of services that are often covered by both public and private payers in the United States, and we are beginning to see more and more utilization of these services due to that increased coverage. So commonly used complementary health approaches include herbal and dietary supplements or natural products, breathing patterns, deep breathing, yoga, tai chi, manual therapies that include massage and chiropractic care, and other, again, mind-body approaches like meditation, guided imagery, relaxation, and then sometimes systems approaches like homeopathy as an example. There is a wide distribution of or complementary and alternative medicine use over depending on which decade of life you might be in. But you can see that the highest prevalences are often in the age range of 40 to 60. So this is often an age group that, as we said earlier, is includes women who are particularly going through uh, menopause, and you can see they have much higher rates of utilization. There is also there is here also a distribution between race and ethnicity amongst use of integrative medicine services. But just, I think the key point here is that it is still highly prevalent and highly used. And I think it is important for us as providers to be asking our patients about their use of these modalities. So there are different domains of integrative medicine and health that I just want, so you have a framework of how we think about this. There's biologically based practices that include herbal and dietary supplements and diets. There are energy therapies that include healing and therapeutic touch, Reiki therapy. There's mind-body medicine that includes approaches like meditation, yoga, tai chi, and manipulative and body-based practices like massage therapy and chiropractic care. And then there are whole systems that span all of these domains. So for example, Ayurveda, traditional Chinese medicine, naturopathy, that includes. In addition, some of the modalities may fall in multiple domains as well, like acupuncture may be thought of as a energy therapy as well as a manipulative or body-based practice. And that's just, again, one example. So I'd like to just explore a little bit deeper some of these practices, some of these domains a bit more. So one is biologically based practices, and dietary supplements is defined as something that contains one or more dietary ingredients, including vitamins, minerals, herbs, or other botanicals, amino acids, and other substances, or their constituents. And the other domain here will be diet, so include weight loss or elimination, or it may include increasing certain foods in your diet. So, for example, in menopausal or perimenopausal, there is often one example is increased consumption of soy. Does that improve symptoms that are associated with menopause? So, oftentimes in our clinic practice, many patients have made tremendous choice in the use of dietary supplements and often are asking questions. So here, something from the supplement cart, and regardless of our personal opinions for or against this trends, understanding the use of herbal dietary supplements by our patients really makes it really requires us to have a particular understanding of a framework. How do we help both support their health and well-being as well as honor their sense of choice and agency? Many patients spend tremendous amounts of dollars out-of-pocket spending on their use of herbal and dietary supplements. You can see here, relative to their spending in prescription drugs, it is a pretty significant proportion. And again, this is older data. There hasn't been an update to this, but again, my suspicion is that the circles will look closer in size than they did 10 years ago. What is important to note is that many patients do use it, roughly 1 in 5 use it, but 2/3 of individuals do not disclose use. This is work that I had done in my fellowship days, and it's amazing how frequently, unless we ask, patients are not going to share. And so I think one of the take-home points is that we want to continue to be able to be comfortable asking our patients about the use of herbal and dietary supplements. Now, commonly used dietary supplements, especially in women's health, include uh, black cohosh, wild yam, dong quai, maca, pollen extract, evening primrose oil, phytoestrogens, vitamin E. Now, in this case, this patient that we used in the case study was asking about the use of black cohosh. And what we know about black cohosh is that the last systematic review, big one, found that there was insufficient high quality evidence to recommend black cohosh. This was used in preparations at a daily dose of 40 milligrams um, to a mean duration of 23 weeks. Since then, though, higher quality studies have reported improvements in the composite menopausal symptoms with black cohosh over placebo. There is significant heterogeneity in these studies regarding herb preparation, but one of the herbs that they all try to standardize to more and more is the triterpene glycoside 27-deoxyactine. The most studied commercial product is remifemin, and it contains 1 milligram of this active compound in one 20 milligram tablet to be taken 1 to 2 times daily. Other dietary supplements to be aware of include, as I mentioned earlier, wild yam, which is used in traditional Chinese medicine, dongxi, which is also used in traditional Chinese medicine. They're heterogeneous results. It's not standardized for the most part, so it makes it very difficult. Phytoestrogens, including soy, red clover, flaxseed, hops, they have heterogeneous results as well because of the non-standardization. And then in symptoms that are often encountered in this patient population, for example, symptoms that are associated with depression, and that includes, there is support for the adjunctive use for supplements like SAMe or S-adenosylmethionine, methylfolate, omega-3 fatty acids, and vitamin D to help reduce some of the depressive symptoms. The challenge with in the United States with herbal and dietary supplements is that the Dietary Supplement Health and Education of 1994 really allowed manufacturers to treat herbs and dietary supplements more like foods than drugs. The government must prove the product's unsafe. Labels can make structure function claims, but prohibits direct labeling to treat and prevent disease. And there is no legal or regulatory definition of standardization. In 2007, they did at least improve that initial Health and Education Act to require that proper controls are in place to ensure that dietary supplements are processed in a consistent manner to identity, purity, strength, and composition. It meets quality standards and applies both to domestic and foreign companies. And there are third-party companies that have looked at the quality and safety of dietary supplements. So the National Sanitary Foundation, United States Pharmacopoeia, and ConsumerLab.com are three independent agencies. And what they do it in slightly different ways, but they confirm the identity and quantity of ingredients declared in the label, confirm that the product is free of contaminants and undeclared ingredients. They have to demonstrate conformance to industry good manufacturing practices, and ongoing monitoring that must be in place. And these companies help do that. Now I'd like to shift gears and talk a little bit more about some of the mind-body practices. And their mind-body medicine includes many different practices from different traditions from around the world, include approaches in meditation, deep breathing practices, guided imagery, biofeedback, hypnosis, yoga, tai chi, qigong, amongst others. Mind-body medicine is defined as the interactions among the brain, mind, body, and behavior, and on the powerful ways in which emotional, mental, social, spiritual, and behavioral factors can directly affect health. It regards as fundamental approach that respects and enhances each person's capacity for self-knowledge and self-care, and emphasizes techniques that are grounded in this approach. Treating patients with mind-body medicine, we have seen, actually reduces the frequency of medical symptoms like pain, fatigue, GI symptoms, decreases the severity of psychiatric symptoms like anxiety, interpersonal sensitivity, and depression, and increases health-promoting lifestyles like spiritual growth, the sense of being connected to something greater than yourself, health responsibility, and stress management. As I mentioned previously, of all the modalities, it has continued to have increase in popularity. Millions of research and discretionary dollars are being spent in the study and practice of different approaches. And there's also a big explosion in the mobile and digital world. In part, this has been accelerated by the recent pandemic. We do know that these types of approaches reduce hot flash frequency both in the short and medium term. These interventions, psychosocial and psychological interventions, help improve menopausal symptoms in the short term, but there is areas where there is an opportunity to learn more. Now, from a more recent perspective, I want to actually just quickly discuss this interesting study that was done 30 years ago that looked at the associations between our perceived stress and the incidence and frequency of common cold. These individuals were given a inoculation of a virus, and healthy individuals, and then saw who developed the cold and for how long. And you can see that the greater the amount of stress, the higher percentage of individuals with symptoms consistent with cold. But they actually looked at 5 different viruses. RV is rhinovirus, RSV is respiratory syncytial virus, and then CV is coronavirus. And when you look at that last graph, you see that there are differences between those that have high stress versus low stress. This study has been actually looked at again. This coronavirus is obviously different in the ones that we're dealing with today, but it shows that individuals with higher stress are more susceptible to it. We also know that the flip, that individuals who practice mind-body practices, they actually have more robust responses to vaccination than those that do not. And you can see that this is something that we perhaps need to talk a little bit more about to better understand its effect. Mind-body practices do affect our immune system from inflammatory pathways, cell-mediated immunity, and biological aging. Just wanted to quickly touch upon acupuncture. We find that acupuncture does help reduce both the frequency of hot flashes, sweats, and it helps improve sleep. In this particular study, there were significant decreases and they were sustained at 21 weeks post-treatment. These were weekly treatments over 5 weeks. So again, I think these studies demonstrate a utility. Now, looking at providers in acupuncture, this is now licensed in almost every state. There's a commission certification process. Massage therapy is licensed also in most states, and chiropractic care is licensed in all states. So where do we turn to for evidence-based information? There are certain resources like Natural Standard, as I mentioned, consumelabs.com, Micromedics, Altmedics, the National Institutes of Health and the National Center for Complementary Integrative Health is another resource, the Consortium for Academic Health Centers in Integrative Medicine. The Osher Center for Integrative Medicine serves as a resource, again, both from a clinical, research, and educational perspectives. And this is at Brigham and Women's Hospital and Harvard Medical School. And another resource is the Benson-Henry Institute for Mind-Body Medicine at Massachusetts General Hospital. So how do we recommend this? Basically, what we want to look is evidence of efficacy and safety. Obviously, if it's high on both fronts, then recommend and monitor. But oftentimes we have inconclusive evidence of efficacy, but there is high evidence of safety. And I think it's okay to recommend a particular therapy or modality. And those that you want to, if it's been disproven or it's unsafe, then we actively discourage. We're oftentimes to balance patient preferences around safety, quality, and efficacy. But ultimately, this is about taking a good history. Again, disclosure is so low, asking open-ended, non-judgmental questions, asking culturally sensitive and culturally appropriate questions, understanding our patients' intentions and expectations for using. And really, we want to really build continuous healing relationships, customization based on patient needs and values, and really respecting the patient as the source of control. There's shared knowledge and free flow of information and evidence-based decision making. So in these cases, I invite you to just, again, do not be afraid to ask your patients about this. And again, there are many resources out there to help support you. Thank you again. Thank you for your attention, and look forward to our questions.